So hello everyone, again welcome to our today's session, and all of you are welcome. So today we are here to talk about a certain interesting psychotic condition that affects most people in our current community or society. So today we are here to talk about schizophrenia. Now, so what is schizophrenia? So this is just the most common psychotic disorder characterized by abnormalities in perception, belief. It tends to affect the ages between 15 to 40. So we find that schizophrenia is associated with dopamine hyperactivity in mesolimbic cortex of the brain in the basal ganglia. So basal ganglia and the mesolimbic cortex, we find that this is the area that is responsible for things like pleasure in general. When you are given food, you feel good and you feel like you want more. It's because of this part of the brain. The incentives, things like addiction, when you are in use of a certain drug, then this is the part that tells you to want more. It's called mesolimbic cortex of the brain. So that's how schizophrenia occurs. So now on the symptoms or clinical signs, they are divided into two. We have the positive signs and the negative signs. So in schizophrenia, we find that when there is higher hyperactivity, that is hyperactivity of the dopamine, it will result into the positive. But when there is low levels of dopamine, this one will automatically result into the negative symptoms of schizophrenia. On the positive sides, most of them you find that the patient is hyper. Yeah. So let's look on the positive symptoms. The first one, you have hallucinations. So hallucinations are just sensing things while awake that appear to be real but instead have been created at the back of our mind. So this is a situation where the patient is they're just imagining things that doesn't exist, but to them they're in their own world. So that one is hallucinations. So under hallucinations, we have some subtypes. We have auditory hallucination, and this one is the most common one. You find that an individual just hearing voices when no one has spoken to them. These voices may be command someone to do something that may cause harm to themselves or others. Yeah. So they can also be hearing footsteps, music, windows and doors banging or opening. They're just fantasies. The second one, we have visual hallucinations, where patients are seeing patterns, lights, beings, or even objects that are not there. Then olfactory hallucinations, this is just smelling of foul or pleasant odor. Odors are smell that appear to be coming from specific or unknown places. The fourth one, we have tactile hallucination. So this one, you find that the patient will be having feeling of something crawling on their body, or even under the skin, or movement of the internal organs. You are just seated and you're feeling that your internal organs are moving or something is crawling on the skin, but in real life nothing is happening. So those are just hallucinations. Then the second symptom now, other than hallucinations, we have delusional beliefs. Very common, especially persecutory delusions. Ideas of reference are which unrelated notices, signs, or remarks are believed to be messages. So these are the things that only patients are able to understand them. Then we have the third one, which is thought insertion, thought broadcast, and thought withdrawal. Patient believes that other people know what they are thinking, either because they can be heard or they are transmitted to the television already. So this is a situation where a patient believes that whatever he or she is thinking in the television or radio, and through that means the patient believes that you are able to read their mind or listen to their mind through the radio or television. So that one is thought insertion. Then now we have things like others like formal thought disorder. We have excitement or agitation, hostility or aggressive behavior, in a position to experience suicidal tendencies. Yeah. Now on the negative symptoms, we have alogia, refers to difficulty with speaking. In some, speech output and are reduced verbal fluency. So in short, alogia is just a situation where patient is unable to communicate well. Then associability, this refers to the situation where patient most of the time they want to lock themselves indoors. They don't want to socialize with others in a given environment. They don't want any company, in short. Then we have avoidation or apathy. So this is the inability or lack of energy to engage in routine activities. For example, the patient will appear to have poor grooming and personal hygiene. So somebody who was used to doing their things on their own perfectly, all of a sudden now they don't want to groom well, and this one also affecting their general hygiene. Then anhedonia. Anhedonia is the inability to feel pleasure, lack of interest in other terms. So in this situation, an individual is, for you to please that person, it's almost impossible. So that's what we refer to as anhedonia. Then we have affective blunting. This is just the decreased facial impression. Let's talk about the types of schizophrenia. Let's see how many types do we have and how they are divided. So the first type of schizophrenia, we have disorganized schizophrenia. So this is a disorder characterized by incoherence, foolish behavior. Then the second type, we have paranoid schizophrenia. This is a disorder characterized by delusions or persecution or grandeur. Differentiated schizophrenia, just from the name. So this one is just a mixed up of, it's a disorder characterized by a variety of symptoms found in several types of schizophrenia. So in this type, all those types of schizophrenia, now in an undifferentiated schizophrenia, it entails phrenic schizophrenia, and this one is characterized by silly and childish behavior. There is also prominent affective symptoms. There are also delusions. Yeah, delusions are common. Then we have residual schizophrenia, and this is of prominent delusions, hallucinations, disorganized behavior with the presence of odd beliefs or negative symptoms. Now of the schizophrenia. It is characterized by marked disturbance of motor behavior, and it may take the form of catatonic stupor. We know that in catatonic stupor, the patient is hypo. The activities are low, and also now we have the catatonic excitement. The patient is hyper, or alternating between the stupor and the excitement. So some of the characteristics of catatonic excitement, how it presents now, we have increased psychomotor activity, that is restlessness, agitation and excitement. The patient is very hyper. Also there is increased speech production, and there is loosening of association. Then under the catatonic stupor now, it presents with mutism. This one refers to the lack of speech, and also there is rigidity. Rigidity means maintenance of posture against efforts to be removed. Like the patient will be presenting in a certain funny posture, and even if you try to remove them from the posture that they are having at that moment, they will try to resist that position as long as they want. Again, it presents with waxy flexibility, means that parts of the body can be placed in positions that will be maintained for long period of time. Also, it relates with the rigidity, but there's a slight difference. So they will present themselves in certain positions, and they'll want to remain in that position for as long as they can stay, or over a long period of time. Then there is stupor. In this situation, the patient does not react to surrounding and appears to be unaware of them. So the patient will be in a certain environment and they don't know anything about what's happening currently in that environment that they are in. That one is referred to as stupor. So there were two people, and they came up with the symptoms according to them of the schizophrenia. So the first person that ranked schizophrenia with certain symptoms was called Snyderian, first rank of symptoms of schizophrenia. So Snyderian ranked schizophrenia with these symptoms. We have the auditory hallucinations, we have delusions of control. He also ranked it with thought broadcasting, thought withdrawal, thought insertion, somatic passivity. This means there is bodily sensations, body, external force. Then medvolation or acts. One owns acts or of experience. Yeah. Now the second person, you have Blailer's 4 A's of schizophrenia. So these are the symptoms according to Blailer's. So this person was called Eugene Blailer, and he cited other symptoms called them Blailer's 4 A's symptoms, which included autistic thinking. Under autistic thinking, this is just the thought process in which an individual is unable to relate with others or environment. So an individual is unable to cope totally with the environment or those in that particular environment. The second A, according to Blailer's, we have ambivalence. Ambivalence is just the contradictory or opposing emotions. Desires for same person but feels bad about him or her. Yeah. The third one, you have associative looseness, inability to think logically. Then the fourth one, remember I said there are 4 A's. So the fourth A, we have affective disturbance. This is just the inability to show appropriate emotional response. So those are according to Blailer's. Let's look on the etiology. So number 1, we have biochemical imbalances, overactivity of dopamine within the mesolimbic cortex. We have environmental factors, e.g. trauma during childhood. We have genetic causes, high prevalence rates in relatives of schizophrenic. Also, we have differential diagnosis. Mania, which is characterized by prominent affective features like grandiosity, overactivity, and liability of mood. Then we have depression, which is chronic schizophrenia may mimic or coexist with depression. Then we have a drug-induced psychosis, present with hallucinations and delusions. Also, we have dementia, which present with impairment in thinking. There is a schizoid personality disorder, which present with delusions. And finally, there is a schizotypal personality disorder, which presents with delusions as well. So on the medical management, it is divided into acute and chronic. So on the acute phase, we can use typical antipsychotics like Lajectin or haloperidol, which have most effect on positive symptoms. So this one works well on positive symptoms of schizophrenia. Patient may benefit from augmentation of antipsychotics with benzodiazepine. So e.g. diazepam and lorazepam. You can give both antipsychotics together with benzodiazepines, and that augmentation will produce effect drug. Yeah, so that's what we mean by augmentation of both benzodiazepines and antipsychotics. Chronic phase, that is chronic management. or management on the chronic phase. We have antipsychotic injections, e.g. we can give Modicate. So may be used in patients with poor compliance. So patients who are not responding to other types of medications, now you can inject them with Modicate. Also, you can use new antipsychotics, e.g. clozapine and olanzapine, risperidone. Now the third management, we have ECT, which refers to the electroconvulsive treatment. So this one is indicated for catatonic schizophrenia and severe depressive symptoms accompanying schizophrenia. So in patients who are experiencing the catatonic type of schizophrenia, and also it's also accompanied by depression, is when the ECT. So we can also do psychotherapy. Remember, you need to counsel these patients, talk to them from time to time, know what they are thinking, and advise them accordingly. You can also do behavior therapy, where you by directing them or giving them instructions or assigning them duties, then you later come and monitor what they've done. Also, you can do the rehabilitation services to provide opportunities to increase skills in living rehabilitation. Outpatient treatment to provide aftercare, maintenance therapy, also the and medical clinic. So this one is being done after the patient has been discharged. Now on the nursing management, these are the things that we can do. The first priority is to ensure safety of the patient and others by removal of all dangerous objects from the surrounding to ensure safety. Also protect the patient during acute episodes and suicide attempts. Remember, during the acute, the patient may abscond from the ward, or they can be having more of the suicidal thoughts most of the times. So they might be in a temptation to do suicide or commit suicide, in other terms. Also, we can administer prescribed antipsychotics and note the progress and side effects. So as a nurse practitioner, while administering the medications on a daily basis, you're supposed to monitor the certain changes, the side effects, and progress of the patient, either positive or negative. So if the drug is functioning well, then we know that the patient is in a good progress. But if there is no change, then you are supposed to submit that report during the change of shift, so that something can be done, or change of drug to the more effective one. Also, you can provide less stimulating environment, e.g. during sleep you give them dim light or less noise and comfortable bed in order for them not to be stimulated. When there is noise, the psych patients are stimulated. So also you can approach the patient with calmness, empathy, and a gentle approach. Also, you are supposed to observe the patient behavior frequently and note any changes. So if there is any changes, either negative or positive, you are supposed to report, so that we know that the kind of care we are giving is progressing good or in a bad way, so that intervention can be taken as soon as possible. Also, you provide a structured environment with scheduled routine activities of daily living. So you put them in a structured environment with the things that they're supposed to be doing on a daily basis, activities of the daily life. So if they wake up every morning, this one should be running on their mind. Like, if I wake up, I'm supposed to be showering, then I take medications, then now you go do other activities. Then now apply mechanical restraints safely if there's justified need. Mechanical restraints applied to tightly may impair circulation of blood. So there is a situation where now in an acute phase where the patients are highly agitated, you may be forced to restrain them on beds or in some corridor rooms to prevent them from harming themselves or rather other patients in the same ward. So while restraining them, you should do it gently so that you don't interfere with the blood flow. Maybe you restrain a patient on the arm, so you do it lightly so that you don't interfere with the blood flow to the fingers now. Also, you can assess the nature and severity of hallucinations. So for the patients who are experiencing hallucinations, you need to assess the nature and how severe they are so that we can intervene and help them as soon as possible. Also, you can distract the patient from delusions and tend to exacerbate aggressive or potentially violent episodes. So we find that distraction can be done by engaging patient in constructive activities. You put the patients on some activities to distract them from thinking like things like suicidal thoughts. Yeah, so you involve them in activities like maybe dance activities, or you put them in something to engage them. Then also you encourage the patient to express feeling as much as possible. Whenever they are having something burning issue inside them, they're supposed to spill it out so that you solve the situation. Then provide food and fluid to the patient to meet physiological needs of the body. Also provide assistance with self-care activities as required. So that's the end of today's lesson. I've talked about schizophrenia from top to the bottom. So one thing that I forgot to mention is that the symptoms that I gave, they're as per DSM-5. So don't go ahead and look for no other symptoms as per DSM-5. The ones I gave are as per DSM-5. Again, thank you again for listening to us, and stay tuned for our next lesson. You can give us support through subscription. You share our videos, you like, and also you comment. Thank you.